It's my pleasure to bring to you from New York at Mount Sinai, balancing benefits and risks of antiplatelet therapies in acute coronary syndromes, filling the gaps in evidence. These are my important disclosures. Let's talk a little bit about the ischemic and bleeding risk, and then, of course, talk about some of the novel therapies that might uncouple this very, very entangled issue of ischemic and bleeding risk. The risk of the determinants of antithrombotic treatment in PCI and the choice of treatments have a lot to do with patient characteristics, clinical presentations, comorbidities, and the procedures, PCI versus CABG, femoral versus radial. And you know that the antithrombotic treatment has to do with balancing this risk of bleeding and ischemic events. There's no question that as you decrease ischemic risk, there's an expense of bleeding. And we've seen this in Triton, we saw it in Plato, and we continue to see this in multitudes of clinical trials. So very important, every single time that we see new studies with new targets, we start to see more bleeding when we reduce ischemic events. And to get back to this, we have to kind of go back to the time course of bleeding versus ischemic risk after PCI. And that has to do with the local stent-related events, the plaque progression and destabilization outside of the stent, preventing those ischemic events that are completely outside of the heart, and then balancing that with bleeding. And dual antiplatelet therapy is trying to get to this important sweet spot, a spot where you have the least ischemic events with the least amount of bleeding. Can we ever get there? The other issue is that the patients are very different. Many of our patients have high bleeding risk. And these same high bleeding risk patients will also have a very high ischemic risk. And so balancing that becomes even a bigger dilemma. So if we look at the prognostic impact of bleeding versus MI, well, they both matter, and it all depends. MI is important, but it isn't as important as a BARC 3C and greater bleeding. It is also important to understand that the risk of mortality goes up every time you have a higher risk of ischemic events, as well as a higher risk of bleeding events. So you see on the right side that many of our patients are living in this horrific zone of higher morbidity and mortality. So MI and bleeding risk are comparable. When we look at the complexity of our patient population, and if you have complex PCI, you have much higher rates of MACE. And in fact, in those patients with complex PCI, a longer duration reduces MACE in complex PCI, duration of dual antiplatelet therapies, because of the fact that the ischemic risk is that much greater. But this doesn't mean that it's okay to not think about bleeding, because bleeding matters. When you look at the high bleeding risk patients, there is no net benefit of long duration of dual antiplatelet therapies, irrespective of complexity. And it's really about the non-high bleeding risk patients where we start to see a very important benefit. And again, very important is the differences in the optimal therapeutic window of platelet reactivity between white and East Asian population. As compared to white males, East Asian patients have lower ischemic events, higher bleeding risk. So the bleeding risk becomes even more important in our East Asian patient populations. We have gone up and down this roller coaster in terms of the duration of antiplatelet therapies after PCI. We started when we were worried about thrombosis, then we became aware of the bleeding, and now we're at a level of equipoise with safer stent platforms, more imaging, more nuanced understanding of DAPT cessation, and important experimental approaches with shorter durations and even aspirin withdrawal. Who would imagine that we would withdraw aspirin? Well, makes a lot of sense. for the most important one for East Asians is the bleeding risk. But it's important that remember that the risk reduction that we used to enjoy in the past is no longer as profound as it was in the past, because we have so many other nice drugs that takes care of the baseline risk. And these novel antithrombotic regimens are really questioning and examining whether or not we actually need aspirin. In fact, the pharmacodynamic studies of aspirin withdrawal suggest that aspirin is doing nothing but increase bleeding. In fact, and very little additional platelet inhibition following stimuli when aspirin is present in presence of potent P2Y12 inhibitors. This is with prasugrel by Paul Armstrong, but there are similar studies in ticagrelor. And in fact, because of that, there are so many clinical trials looking at aspirin-free strategies, and we thank our Asian investigators for really contributing tremendously with STOP-DAP2, Smart Choice, TICO, STOP-DAP2 ACS, with a lot of data now. And as you know, our group conducted the Twilight study for the very first time in a double-blind randomized controlled trial withdrawing aspirin in patients who would be on after 3 months of open-label aspirin and ticagrelor. And what we found that over a period of the next year after you enroll the patients, continuing with aspirin and ticagrelor exposes patients to 7.1% of BARC 235 bleeding, and this number decreased down to 4%, with the numbers needed to treat at 33 by just taking aspirin off. What happened to death, MI, and stroke was absolutely nothing. And in fact, we've concluded that in high-risk patients who underwent PCI were treated for 3 months of aspirin and ticagrelor without any major events, that the strategy of ticagrelor monotherapy gave less bleeding without increasing ischemic events. In fact, we saw this very much profound benefit in the acute coronary syndrome patients who came in, and we were able to receive a class 2A recommendation in these patients. We also saw in high bleeding risk and complex PCI that you reduce bleeding without increasing ischemic events in both of these populations. Very, very important finding. We had studied the ACS patient population, but the only group that we had not studied were STEMI patients. But our Korean colleagues in the TICO study did include STEMI and non-STEMI, and then they were very, very open to share the data with us, and we just presented this and published this in Circulation this past 2 months ago, where we combined this IPD meta-analysis of Twilight and TICO, individual patient data with all ACS patients, showing the incremental benefit of reducing bleeding without increasing ischemic events in these very, very difficult ACS patients. We also have some data on the importance of P2Y12 monotherapy after complex PCI. This is another IPD analysis led by my colleague, Dr. Marco Valgemigli, looking at a meta-analysis of 23,000 patients, 6 randomized trials of GLASSY, Smart Choice, STOP-DAP2, TICO, and Twilight, showing similarly a very, very important benefit of reducing bleeding events without increasing ischemic harm, and in fact, having a positive outcome in net adverse clinical events in terms of P2Y12 monotherapy. For a long-term maintenance, the only trial that has looked at this is HOST exam, where they did over 5,000 patients. And again, our Korean colleagues did this work, and we thank them for this. And I believe that this is such an important study in patients who are event-free after DAPT, after PCI for 6 to 18 months, randomized, uncouple the anti-side, which reduces the hepatic synthesis of factor 11, or antibodies that bind factor 11 and block the activation, and then some small molecules that bind reversibly at the active site of factor 11 and block activity. The programs are massive. There is the Librexia programs, the Ozalia and Lilac programs, as well as the Pacific programs, all of them taking on a very, very large scale of multitudes of patients at hand. Most of these are ongoing. The asundexian Pacific AF program was the phase 2 program with 750 patients showing complete inhibition of factor 11 with less bleeding. They had efficacy data that was lacking, and they took that on. The other phase 2 program was their Pacific AMI program. On top of DAPT, they showed a significant reduction of dose-dependent inhibition of factor 11A without increasing bleeding, but no clear signal towards reducing MACE, very few MACE events, and they're waiting to see if they will go ahead. We do know that Pacific Stroke program, that phase 2 program also was done with asundexian that reduced ischemic strokes among patients with atherosclerosis. They have 2 phase 3 programs, Oceanic AF and Oceanic Stroke. We all know that Oceanic AF was stopped prematurely after 13,000 patients were enrolled for lack of efficacy, but Oceanic Stroke is going forward. Milvexian in stroke has been very well. This is another small molecule by that's being evaluated by in this axiomatic study, the SSP study, where there was symptomatic ischemic stroke, different dosing, multitudes of different dosings with very, very little impact on bleeding, and very important association, found no fatal bleeding. The Librexia program is extremely large, a stroke program, an acute coronary syndrome program, and an atrial fibrillation program, all encompassing about 50,000 patients in these programs ongoing. The monoclonal antibodies, abicilimab, was evaluated in VTE with excellent results, no bleeding, and in the ongoing atrial fibrillation trial, Ozalia was just presented at the AHA showing fantastic, no bleeding issues and very, very good, good results. And the Lilac study with patients in AF and moderate to high-risk ischemic stroke is ongoing. So the take-home messages, ladies and gentlemen, the present-day antithrombotic therapies are working well. They're reducing ischemic events, but it's always as a very important expense of bleeding. Balancing ischemic and bleeding events are extremely important and ever so crucial. And at the moment, these emerging antithrombotic regimens, especially in factor 11 inhibition, show very promising results in uncoupling ischemic and bleeding risk. I want to thank you for your attention, and I look forward to the discussion after this presentation. 감사합니다.